We're going to continue on with some of the female reproductive physiology here. So we'll come back to oogenesis here in the fourth video as well. So the process of creating oocytes is oogenesis, and so female cycle is going to produce one matured oocyte per cycle that we have. And this process begins in the fetal period, unlike that of the male. And so all of the oocytes have gone through thymic reckoning, and so we've seen them through the immune system, so we have no need for a blood ovarian barrier like we do in the blood testes barrier. That's there. So the oocyte itself is going to continue on to a primordial follicle, and then from there into a primary oocyte. And at that point, it's basically going to be stalled. And so primary oocytes begin to go through prophase one, and then they stop there. And they're going to stay there until essentially puberty. And the first oocyte that is stalled out is then going to start to continue on. And so at puberty, one of those primary oocytes gets called on, and it's going to finish up the first meiosis, and then it's going to start to go through second meiosis, and again it's going to get stalled out at metaphase 2. And so when with its first cell division, it's going to convert from one cell into two cells. One's going to be smaller than the other. That's going to be our first polar body. And then we're going to have our secondary oocyte from that point on. And then that one's going to continue on, and it's going to continue on until metaphase there, and then it's going to stop. And with that, we have essentially two cycles in the female, both the ovarian cycle and the uterine cycle. And so two things are going to kind of happen simultaneously, but we'll talk about them separately, even though they're happening both at the same time. So with each essentially 28-day cycle, we have the maturation of an oocyte. And so we have the follicular phase of the ovarian cycle itself. And this is all in a sense about the follicle. And so this is getting us from the primary follicle into a secondary follicle and into a Graafian follicle where it then can be ovulated. So up until day 14, where ovulation then occurs. Then we have the luteal phase. Luteal phase is going to continue on until day 28, assuming that there is no pregnancy, and then menstruation is going to occur on essentially the next day. And so it's the luteal phase because of the corpus luteum. So that Graafian follicle had changed into a corpus luteum and then moved on from there. So during that follicular phase, the job of the ovary is to take those primary follicles and develop them into a fully formed secondary follicle. That's there. And so back in the last video, we talked a little bit about the production of those follicles and kind of the changes that happen there. And so with the primary follicle, we said that we get a couple layers of cells. And so we go from the primordial follicle into the primary follicle, and now we have a couple of layers of cells. Those couple of layers of cells are a combination of cells that are going to surround the oocyte themselves. And so we have the theca folliculi and the granulosa cells. Those are surrounding the cell. We have the zona pellucida that is around the cell itself as well. And this is now starting to form that open space of the antrum. The secondary follicle is going to have a larger antrum. It's going to continue to grow inside there. The layers of cells surrounding the oocyte are going to continue. So we're going to have the zona pellucida continuing there, and then we're going to develop a corona radiata as well. That's there. The fully developed follicle then essentially is moving towards the epithelial surface of the ovary, and at day 14, it's going to then rupture. And so the oocyte itself has gone through and completed meiosis 1, and it's now stuck in meiosis II, waiting to be fertilized before it's going to continue on there. And so here we have going from that primordial follicle, just those squamous-like cells, we get a primary follicle, continuing to add cells to it. The antrum here starting to develop late in the stages of the primary follicle, and then secondary follicle, large antrum, ovulation occurs, and the zona pellucida and the corona radiata go out with the oocyte. And then that's going to take its journey down through the fallopian tubes. Ovulation itself occurs typically, in a sense, at day 14 of a typical 28-day cycle that's there. Because the follicle itself is basically rupturing, it is tearing through the cells and so on there. Sometimes women can experience what's been referred to as Mittelschmerz, which is essentially a twinge of pain, feeling like it has just ruptured at that point when they do actually ovulate. That's there. Most of the time, you get a single secondary follicle ovulating, but once in a while there are two oocytes that ovulate, and that's going to give us fraternal twins if both of them are fertilized. This is the reason why with things like infertility treatments and increased hormones, that will increase the number of oocytes that are developed. And so you can have multiple uh, oocytes be developed with one single cycle that's there. If the fertilized egg is then going to divide after it's been fertilized, that's how you then get an identical twin, because it has taken that one cell and divided it into two equal cells, even though in a sense it wasn't supposed to. So here we just have ovulation itself, kind of the expulsion. Again, remember that the fallopian tubes, the uterine tubes, don't actually touch the ovary in terms of kind of sealing it in there. So it is open and it does need to make its way into the fallopian tube from there. If ovulation doesn't occur, there's the potential for cystic formation that's there. So the top photos are cystic ovaries, polycystic ovary there on the top right for those. And then the bottom two pictures are what we call teratomas. These are actually tumors that can grow basically any kind of tissue. So they have the ability to develop. On the left-hand side there, you can see teeth that are actually forming there. And on the right-hand side, you can see some hair. So after ovulation occurs, the oocyte is going to travel down through the fallopian tubes, at which point, at some point, potentially fertilization occurs. And then from there, it's about a 6-day journey from the fallopian tube all the way into the endometrium, where it then implants. This process itself does take several days. So if ovulation occurred on day 14, that means that by the time that implantation occurs, it's already day 20. And so there's only 8 days left basically before menstruation along that process. And the cells that we started out with, one egg, one sperm cell, both carrying half of the chromosomes, come together to give us a zygote there, and then it continues to divide and divide and divide, and then we'll talk about the different components of the numbers of cells and what we call them a little bit later on in the next video when we start to talk about the cells. After day 14, then we go into the luteal phase. So this is the corpus luteum essentially is in control. And so the cells that remain behind in the ovary from the follicle are what are going to then continue to produce progesterone and estrogen all the way up until menstruation occurs there. So if pregnancy does not occur, the corpus luteum is going to degenerate and start to essentially decrease its hormones by day 10. And so, or 10 days afterwards, so roughly day 24. So now we've got a drop in estrogen, we've got a drop in progesterone levels at this point. That leaves the endometrium of the uterus to start to degenerate as well. on there. However, if pregnancy does occur, that corpus luteum is going to continue to be functional for about 3 months, so the first trimester. The placenta needs to get large enough in order to produce enough estrogen and progesterone, essentially to take over the job of the corpus luteum at that point. So here we have oogenesis itself, going through, and we can see kind of the different stages there. That is happening up until the ovulation occurs there. And we're going to go from essentially one cell. So one cell is what we start out with, and then we end up with 4 cells. The thing here, though, is that when we look at it, 3 of those cells are non-functional. These are all polar bodies. And so the polar bodies themselves are a non-functional cell. And we'll see later on that in terms of the sperm cells start out as 1 cell and we end up with 4 cells. The DNA itself, in terms of the chromosomes, do still get split here in the female as well. And so we end up still with only a 1N or 23 chromosomes in our oocyte, whereas in the male, in the sperm, we have that same number as well. So 23 chromosomes, a 1N cell, as far as the chromosomal numbers themselves go. When it comes to the ovaries and eventually the uterus, they're under the control of hormones. And so on day 1 of the cycle, so day 1 of the cycle begins with the beginning of menstruation. So gonadotropin releasing hormone, GnRH, stimulates from the hypothalamus down to the pituitary gland to release FSH and LH. FSH and LH levels are now going to rise. Those levels are rising in the beginning portion of the cycle itself. Estrogen levels are going to start to rise. Those will then knock down FSH and LH levels. But then just before ovulation, LH is going to start to surge. And so the pituitary gland starts to increase and increase and increase LH, and we get this LH surge. And this is going to be vital for ovulation. So if LH does not surge, if it does not spike just before ovulation, we don't get ovulation. So that has to happen coming up around day 12 or so. It starts to rise really, 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 really high, and that's going to lead to ovulation. So this can be a point at where infertility may be coming from. And so if that LH surge does not occur, you're not going to get ovulation, and that could be a source of infertility in the woman as well. From there, that LH is going to be the trigger that also, after ovulation, helps the corpus luteum develop from the follicle itself. And then the corpus luteum is then going to produce primarily estrogen and progesterone, as well as inhibin, to keep the endometrium viable all the way through to the end of the cycle itself. Eventually, if pregnancy has not occurred, and so if we haven't had pregnancy in terms of fertilization occur and implantation occur, those levels are going to fall off. And so by day 26 or so, so 10 days after is day 24, by day 26, those hormone levels are now starting to fall off quite a bit. FSH and LH are now able to start to rise again, and this is going to essentially start the cycle all over again. And so the endometrium, in terms of the uterus, which we'll talk about in just a second, is then going to die and slough off and move on from there. So here we have the hormone influences coming down. So hypothalamus releases our gonadotropin releasing hormone, anterior pituitary gland releases FSH and LH. That starts the follicle maturation process, and LH really surges right there just before ovulation, and then takes that follicle from the Graafian follicle into the corpus luteum. The uterus goes through a cycle as well. And so the uterus is going to have to go through changes in terms of growth and death of the tissues themselves that are there. And so the uterine cycle begins again on day one. And so day one through roughly day five, sometimes less, sometimes more. It's then going to uh, have the functional layer shed off. And then by, if it's 5 days, 6th day comes around and now proliferation begins again. So we go through menstrual phase, then we go through the proliferative phase. So days 6 through 14, the endometrium is growing and growing and growing, increasing in its cell numbers, adding blood vessels and so on to the endometrium that's there. Day 15 after ovulation becomes the secretory phase. And so essentially the endometrium is again still growing, but it's getting ready for implantation. It's getting ready for the potential embryo that's coming down to be able to implant into the uterus itself. So here we have a picture of essentially everything together. The hormones, the ovarian cycle, the uterine cycle, kind of all imposed on one another, and we can see what's happening with each phase that's there. And so in through the ovarian cycle, we're talking about the beginning here. So the follicular phase, we have FSH and LH levels kind of lower. Estrogen levels are starting to rise, going up. By day 14 here, oops, I kind of got off there. By day 14, we have ovulation. LH has surged just a couple of days beforehand. So day 12, that surge was going up. LH is then going to create the corpus luteum that's there. Estrogen, progesterone going to keep that secretory phase growing in terms of the endometrium until roughly day 28 there, where things can then slough off if pregnancy has not occurred. So menstruation itself, if fertilization has not occurred, there's been no hormones coming from the embryo at that point, is going to lead to a decline in estrogen progesterone, which then, as we mentioned before, causes the spiral arteries to kink. So they're going to stop blood supply up to the endometrium, and the endometrium then dies. And then all of a sudden, the spiral arteries themselves one last time are going to open wide open. And that's going to basically push off all of that endometrium off of the uterine wall. And then uh, through that, uh, the functional layer is going to be sloughed off. Smooth muscle contractions of the uterus are going to push it down through the cervical canal and into the vaginal canal and then out of the body from there. Just another picture kind of showing the estrogens and progesterone, LH and FSH throughout the cycle. And again, another picture showing the endometrium and the ovarian cycles. So estrogen, progesterone, we've talked about as having effects on the ovaries, on the uterus, but it also has effects just like testosterone did outside of the reproductive system itself. And so as puberty ensues, so again, sometime between ages 9 and 12 or so for females, but could be as late as age 15 or so in there, and even younger nowadays as well than age 9 sometimes. That's going to get the body ready for reproduction. And so we're going to have changes that occur to the body as well. The uterus is going to grow and change positions. The uterine tubes, the ovaries are going to start to become functional that are there. The uterine tubes, the smooth muscle contractions, the ciliated cells all become more active at this point. The vaginal secretions start to change with the cycle itself as well. And then external genitalia and the mammary glands themselves then start to grow as well. And the mammary glands are oftentimes one of the first signs of puberty in females. And so the development of what we call breast buds occurs there. Then you start to have things like hair growth. And so you start to see axillary and pubic hair growing as well. Then, kind of some of the changes that then go along with the need for the body to change for reproduction. So the pelvis itself starts to widen, the iliac crests become further apart, the bones themselves start to decrease in their mass that is there. We get changes in terms of the movement and disbursement of adipose within the female body as well, and so it goes around the hips, increases around the mammary gland tissues. For the female sexual response itself with females is a little bit different than that in males, in that primarily in terms of that, there's no refractory period. So the stimulatory process in terms of sight, emotions, touch, and so on with females as well causes a change within the body itself. And so we get an increase in blood flow to places like the breasts and the chests that are there. We get blood flow increasing to the clitoris, and so just like in the male, the glands itself then engorges in the female as well. With that, we get an increase in blood pressure in and around the reproductive organs themselves. And then in terms of orgasm, there's no ejaculation with the female, but that causes contractions of the uterus itself and actually causes the uterus to, in a sense, stand up. And so remember that the uterus is kind of folded over the bladder with orgasm that will cause it to stand up. Although that does occur, and it does actually cause the cervix to kind of dip down further into the vaginal canal, it is definitely not required for pregnancy to occur on that. And so it's not required in females. The female does have a or does not have a refractory period, so there's no change from parasympathetics to sympathetics in females. In terms of that, there can be essentially more than one orgasm throughout a sexual experience with a female rather than that of the male. So the downsides potentially of reproduction is that there are organisms, bacterial and viral infections that can occur that can cause damage to the reproductive organs as well as the urinary system in both males and females that are there. So it affects both males and females regardless of the infection itself, but the symptoms are sometimes slightly different. So gonorrhea, this is a bacterial infection. This is generally going to be, in a sense, on the genitals themselves. In males, typically they're going to have more symptomatology than that of females. And so they're going to get urethritis, essentially inflammation of the urethra, painful urination, and oftentimes discharge from the urethra as well. And so all of those are typically going to cause, in a sense, a male to kind of notice that something has gone wrong. In terms of the reproductive organs themselves. In females, however, sometimes they have no symptoms whatsoever. So 20% of individuals with gonorrhea may have absolutely no kind of symptomatology whatsoever. But it can be similar to that of the male in terms of discharge that is there. May see spotting, things like that in the female. And sometimes those may be essentially just kind of confused with normal changes of their cycle that's there. The good thing is that they are treatable, and so antibiotics are able to treat the infection itself. The downside is that they are becoming more resistant to antibiotics. Syphilis, another infection. So we have another bacterial infection here. This one itself is going to go through stages, however. And so the first stage, primary syphilis, is essentially they get a painless canker, kind of a fluid-filled bump on their genitalia, whether it be male or female, and then it goes away. And so they may not necessarily know that they've had it, potentially. Secondary syphilis shows up later on. This is going to look, I don't really necessarily want to call it like a flu or a cold or something like that, but they may have a fever, body aches, joint pain, things like that. So they may just think that maybe they're overly tired, things like that. They may get a skin rash that goes along with it. And then again, it goes away. From there, it can go many years before tertiary syphilis. And so tertiary syphilis has now spread from the genitalia and made its way on to other places like the brain, so CNS, blood vessels, bones, skin. And so we can see evidence of syphilis even in bones of people that have been long dead, as those changes are still seen. Good thing again, it's treatable. Penicillin. Nice, easy treatment. Again, becoming more resistant as well. Most common STD or STI in the US is chlamydia. This has a large number of infections and also has the largest number in terms of PID or pelvic inflammatory disease. This is common in females that have not treated their chlamydial infection. It basically makes its way into the pelvis and is then going to cause problems inside the pelvis itself that's there. So penile discharge again, vaginal discharge. Um, it can cause pain in the abdomen, the rectum, testicular pain, all kinds of painful components in terms of the female, intercourse, menses, and so on. In As it spreads, in a sense, throughout the body, it can then move through and cause arthritis, that's there, and can also end up causing urinary tract infections as it moves into other places as well. Again, treatable with tetracyclines. Viruses also infect the reproductive organs themselves as well. Genital warts, the HPV virus, same one that is going to cause cervical cancers, also causes genital warts. That is there. There are many, 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 many different strains of HPV. Some are more viral than others in terms of their infections. And then we have herpes. Herpes comes in a couple different varieties as well. Those often characterized by genital infection are typically type 2. Um, same Similar type of virus itself is also responsible for cold sores as well on there. And so different virus, slightly different place on the body as well on there. No treatment for viruses. Uh, the viruses themselves we can simply attempt to kind of knock down sometimes, especially with like cold sores. So we do have acyclovirs and antiviral types of drugs that have the ability to kind of decrease the timing of the infection. And that does it for this one.